Welcome to the DaVinci Hour podcast. I'm your host, Dr. Maxwell Cooper, and in this podcast series, I interview physicians, medical innovators, and entrepreneurs making an impact on healthcare. This podcast is produced by DaVinci Academy, a multimedia medical education company that provides podcasts, video courses, and digital textbooks. You can see more on our website, www.dviacademy.com, and our YouTube channel, youtube.com/c/DaVinci Academy Med. This podcast is sponsored by Doc2Doc, the personal lending platform designed for doctors by doctors. Do you have some big expenses in the near future? Maybe you're moving, applying to residency or fellowship, fixing up your car or home, or starting a new practice. Doc2Doc believes that traditional lenders overestimate the risk of lending money to doctors, residents, and medical students, focusing too much on the challenges of their financial past and giving them insufficient credit for the promise of their financial future. Check out Doc2Doc's personal loan options at doc2doclending.com/DaVinci. Hey everybody, welcome back to the DaVinci Hour podcast. I'm honored this week to be joined by Ian Koons, who is the co-founder and CEO of a new startup called Karoo Health. So Ian, welcome to the podcast. Really appreciate it.
Thanks, Maxwell. Happy to be here.
Awesome. So maybe give us a little bit of background on, how your journey through entrepreneurship and how you got to where you are now.
Yeah, so the journey through entrepreneurship actually started when I was 15. My parents wanted me to get a job, and I didn't want to get a real job. So my best friend and I ended up starting a curb painting business where we would go door to door. We would, put up flyers in the morning, come back. And so that was kind of my journey to entrepreneurship. But fast forward, ended up starting a healthcare staffing consulting firm. So we'd staff nurses, PAs, NPs, kind of up and down, kind of the Mid-Atlantic, Northeast. And then from there, was recruited to run really kind of growth and M&A for two private equity VC-backed women's healthcare companies, one in the obstetrics space and the other in fertility. And then about 2 years ago now, was talking to a good friend of ours, Chad Moore. Chad founded Eligo Health Research, and he was talking to me really about wanting to do something in cardiovascular care, really stemming from the kind of the disjointed, unsupported experience his dad had with cardiovascular disease. And it just so happened that my best friend had a heart attack and passed away at 29. And so I always thought, is there a care delivery model and or a technology that I could create and or deploy that would have prevented the outcomes of the people I love? So the light bulb went off. My co-founder and I ended up doing kind of a deep dive on the current state of cardiovascular care. And through that, we got connected to the research in Mark McClellan, who was commissioned by the American Heart Association, basically to say, why are outcomes getting worse, not better? And unsurprisingly, the findings of that research was there's no value-based care, in general, kind of misaligned incentives with providers. And so we ended up kind of doing this walkabout, talking to countless cardiologists all over the country. And we would ask them one simple question, which is, if you had unlimited time and resources, how would you build a delivery model that actually put patients first, drove those outcomes and change? And they universally came back and said it had to be this hybrid delivery model where we're partnering with existing cardiology practices, networks, and systems, and enabling value-based care through these wraparound services, nutrition, health coach, and the technology to really shift from the current fee-for-service world to value-based care arrangements. And really focusing initially on the sickest of the sick, cardiovascular patients that need us the most.
Yeah, thanks for that overview. That's really interesting. I think it's interesting that you kind of initially started with going to the clinicians, the end users on the ground, and saying like, what if you and I think that's an interesting way you put it. If you could do anything, like what would you do to solve this? I think that's really, I feel like some startups kind of miss the mark sometimes with that.
Yeah, no, you're spot on. So we specifically did this, and this is from lots of lessons learned and scars along the way from entrepreneurial and businesses we've been a part of, and that we're investors in and friends of, where we think that a lot of these VBC companies have failed, not intentionally, but they've gone to the payers directly to get delegation, which has ultimately led to this siloed where, there's nephrologists, oncologists, and PCPs not knowing that their own patients are essentially delegated to this other entity. And so we really were mindful to create this bottom-ups approach where, we're partnering and building trust initially with those cardiologists at the local level.
Very cool. So I guess what in a general sense, what stage are you guys at right now? And then maybe walk us through your platform and your program, like how it works both on the patient end and then on the cardiologist end.
Yeah, so in terms of stage, so we can go through it, but we just are closing and announcing our second round of financing, our seed round. So we ended up raising an oversubscribed amount led by First Trust Capital, sorry, out of Chicago, and that's really going to help us operationalize and launch with our first contracted partners in both Arizona and New Mexico,
Awesome.
where we are launching and partnering with 100 plus providers, cardiologists, 165,000 patients in over those two states. So that's kind of what the proceeds are used for. But ultimately, what the services in which Karoo provides is really the wraparound services and the technology to be successful within value-based care. And so traditionally, the way that we think about it is cardiologists and practitioners are really good at medicine. They're really good at talking and being there for their patients, but they don't have all the resources necessary to be successful in the kind of new wave of value-based care that requires additional resources and technology to truly be successful in value-based care. And so with our initial launch partners, they actually went to the payers themselves after being really frustrated with seeing their patients end up in the ED over and over again. And they went to the payers saying, hey, there's got to be an alternative way to be compensated. And ultimately, when the payers asked the providers, hey, how are you going to be successful? They were like, we don't know. And so it was kind of opportunistically that they reached out to us to help be that initial partner. And so traditionally within the patient population in which you're starting, so think of kind of the sicker of the sick, they have a typical PMPY of 47,000 on average. These are, chronic patients that they're going to visit the ED 8 to 10 times. And the typical patient experience in its current form, and it's no fault of the patients and no fault to the cardiologist in a fee-for-service model, is, this patient waits weeks and weeks or months and months to get in to see the cardiologist, only to really be told, work out, be healthy, see you later. And that person who's already hypersensitive to their condition will have, tachycardia, or they will feel something, and they don't know or don't have the support to maneuver through. Is this something that they should go to the ED for? Should they get the attention for and the support in their journey to make those changes that they would recognize? Let's not go to the ED. Only for them to call their cardiologist, who is closed, and it'll say, if this is a medical emergency, go to the ED. And so instead, we've kind of re-engineered the way from a support and wraparound of that practice. And so in the new wave of the Karoo patient experience, that patient will come in. We will risk stratify through our technology of the inclusion criteria of this patient meets is Karoo eligible. And then when that cardiologist meets them and, they're typical of work out, be healthy, they'll say, Maxwell, you need additional services that our partner Karoo can really help effectuate this care plan that's going to help stop that progression of cardiovascular disease in the form you have it. And so once they do, they'll say, there's a Karoo coach waiting for you in the lobby. And our Karoo coach will meet that individual, go through it, and say, Maxwell, you have CHF, or you have that, to give them really the education that they need and effectuate that care plan. And that care plan, for the way that we are an extension of the providers, So whether that's nutrition is the primary driver of their cardiovascular condition, or it's the health coaching from a psychological, we're there to help support them, giving them 24/7 access and a member to really effectuate that care plan. So instead of text, they have a 24/7 text access, and their daily weights. And so these are things that are text message on the front end, but on the back end, they're actually on top of the EMR. So in its current form, a cardiologist will kind of send their patient out to the ethos and never get them back and know where they are. Instead, our technology through APIs is on top of our partner's EMR. And it'll kind of effectuate saying, hey, Maxwell, weight has gone up 3 pounds in 3 days. It flags that for built up a fluid. We need to reach out. There likely will be an event. And so these are the things that we're doing. And then on the back end, we're really transitioning those providers to value-based care, right? How they're doing from a contractual perspective, and also defining what's good within a network, right? What percentage of the providers' patients are adhering to medication or adhering to, kind of smoking cessation, all of those things to define what are those successful metrics we need to be successful within a, value-based care arrangement.
It's really interesting. And, it's like you said, extending what the provider offers, because like you said, a physician these days in clinic, if they're lucky, can see someone 10, 15 minutes and then they're on to the next one, if that even. And every patient's experienced that. You wait and wait, and then you talk to them for 5 to 10 minutes, and then that's it. I think it's really interesting that you're extending that coverage and that, further, allowing that provider to essentially, carry out their treatment plan in a monitored way. I'm curious from the monitoring standpoint. So the physician, you said it's built onto the EMR. Can the physician essentially track their patients and see like how they're doing, or is that through is that something more on your guys' end that you're providing?
No, so RPI, so it's integrated into their EMR. So at any time they can see how Maxwell is tracking based upon their care plan that they have essentially ordered, and see how we're doing as a team against that care plan.
Interesting. I'm curious from the reimbursement standpoint, is how is this, I guess, essentially, how does your business make money? And then what's the incentive, obviously, to deliver great patient care, but what also, is there any incentive financially for the practices as well to partner with you guys?
Yeah, absolutely. So there's several in other disease states, SaaS offerings, or, vendors that they'll charge a fee, or they'll charge, something for their services or technology. We've approached it a lot different, saying that we're entering actually as a percentage into JVs directly with our cardiologists. And so we only succeed financially if the cardiologist and us are successful, right? So everyone is aligned in taking that step and moving forward together as a united front. So we're going into risk-based contracts and giving those revenue lifts to those providers. So essentially the value add to the cardiologists and the groups is they're offloading those hard to deal with cardiac patients into a financially aligned partner. And then we're sharing in the savings into the arrangements that we have with the payers with the provider group. So they're seeing that revenue lift that they otherwise wouldn't see. And they're most importantly doing right by the patients that they know are going to show up in the ED, but they, morally, fundamentally, want to do right by the patient.
Great. No, and I think that's it, especially for certain conditions like heart failure or something like that, where you see it time and time again. These patients, like you said, they're in the ED over and over again. They get short of breath or chest pain or whatnot, and they always go back, and it's a terrible burden to the healthcare system in terms of finances, and it's a bad experience for the patient. Like, who wants to go to the ER on a regular basis?
Yeah, it's interesting that you say that. One of our cardiologists runs a very, very large group and was on call 6 months, a year ago. And I tell this story often because I think it's indicative of our current system and the way that cardiologists are feeling. And so I asked him, he was on call for the weekend. I asked him how it went. And he said, listen, it was great, but we had 55 cardiac admissions in a single weekend from just his practice. And you start thinking about that of just how many people should be there. And that was the question we ultimately asked is, of these patients, how many of them needed to be here? And he undoubtedly said, listen, 50 to 75% of these absolutely don't need to be here with basic intervention support, throughout the journey. And so it's just kind of indicative of the system in which we, currently operate.
Very cool. Very cool. And as far as the staff support, you mentioned that there's a coach involved for each patient. I guess, is there also like you said, nutrition is obviously a huge part of, is there like a nutritionist component or dietitian component that you guys are providing as well?
Yeah, so it's twofold. So the quarterback of our team is the health coach, and their seasoned experience, mostly in behavioral change, right? Of getting they typically will be licensed social workers or of that, kind of background and expertise, really to effectuate support, be the quarterback of that team. But in certain cases for cardiovascular disease, the real drivers of that is nutrition is the issue. It's probably 20 to 30% of our patients will ultimately need nutritional services. The primary driver of that progression of cardiovascular disease. However, we do have smoking cessation and others that are also contributing to that progression. And so we ensure, some patients may have it and some may not.
Interesting. Are there certain patient, I know you're obviously in the sphere of cardiovascular care, but even within that, are there certain patient populations you guys are initially focusing with in your launch? And if so, why those specific patient populations?
Yeah, so we're really focusing on the sicker of the sick population to start. Part of that is we can effectuate the greatest change with that population. So these people have CHF, they have advanced, cardiovascular disease in one form or another. The average kind of PMPY on these patients is, 47,000, right? And so when we risk stratify that patient through our technology, there is an inclusion criteria based on, CPT codes, ICD-9, 10, that we deploy that meets that. And so it's really in the initial phase of that sickness where, from an attribution perspective, it's also easier to demonstrate a direct correlation in cost and spend to the activities in which Karoo provides, that we don't have to go to the payers and fight over attribution, because if someone does or doesn't go to the ED 8-10 times with primary diagnosis of cardiovascular, it's an easier attribution. Now, over time, as we expand and grow into other markets and work with large payers, which we are in health systems, then we will ultimately deploy kind of a lighter touch model for the broader cardiovascular population. But if you think about a typical cardiologist panel, about 50% of our patient panel is what we deem Karoo eligible. Now, if you talk to cardiologists, typically they're going to refer about a third of their patients to Karoo.
Gotcha. Interesting. Okay. And then, like you said, you just announced your recent fundraise. Congratulations on that first. And then I guess second is, what do you think, what are some things you did well, like as a company, and then also in terms of just kind of your guys' overall mission to, facilitate that fundraise? I guess what made you guys successful in that regard?
Yeah, I mean, I think we're fortunate in this economic time at this stage to get funded. I'm not naive to think otherwise. I think if we had started our raise months later, I don't know if we would have actually gotten funded. But through the process, we've made great strides. We've hired, really well-known people. We've demonstrated the desire from both the payer side and the network side and cardiologist side, to move into value-based care in an alternative way to get paid for the services that they currently render. And so I think all of those were um, really the things that we've demonstrated that ultimately led to being funded with one of the best kind of healthcare VCs out there in First Trust, who led our round, and Panoramic Ventures, who led our previous round. I think having those kind of blue chip VCs believe in the model and really have a testament to kind of the belief of where the market is going. I have a certain viewpoint that version 1.0 of value-based care was just direct delegation to risk-bearing PCPs. And I think through the OIG memos and other things from payers that have come out recently to say, the PCPs are fantastic, but they probably shouldn't be managing complex congestive heart failure. And so either they're mandating a subcap to cardiovascular networks, or a direct delegation that they've done in other disease verticals like oncology and nephrology, right? And so that's kind of where the puck is. And I think there was full alignment with First Trust and Panoramic and our notable angels that's where the future is heading. And we have the team and the expertise to be the leader in what really is the greatest, I'll say, the greatest crisis, right, of our healthcare system, which is cardiovascular disease.
Sure. No, that makes sense. I guess what's your advice for like a budding entrepreneur out there who wants to, they've reached a stage where they feel like they need to raise money. What would your advice be for getting like these high, notable investors, investors that high value investors, if you will, for their startup? What's your advice on that?
I mean, I think it's twofold, right? I mean, one, I think it's having them solving a problem that is unique to them, or that they're passionate about. Because the reality is, as an entrepreneur, you spend every waking hour thinking about solving this problem that has burned into you at some point, right? And I think that a lot of VCs understand that when they are talking to the young budding entrepreneur, that there's a specific problem that they're trying to solve that they're connected to in some way, whether it's personal or they're just super passionate about it. I think that's one. And then just really doing their diligence in trying to recruit that top team that can supplement the functional areas that they may lack, right? Like my co-founder is, one of the best, finance executives in the entire industry. Our COO was the COO and ran ops for City Block and Somatis, right? And then our rest of our ops team are VBC experts that have scars and scars of 10, 15 years, in the early days of VBC. And then really taking, recruiting those type of people that see the North Star of ultimately, hey, they want to join an organization that has that North Star, that they're trying to solve something paramount to society.
Very cool. I guess as we get close to closing out here, I wanted to ask you kind of just I know you don't have a crystal ball, but I guess your thoughts on value-based care and like where startups and, digital health and technology will kind of play that role in the next, I don't know, 2-5 years or so, like where you kind of see those trends going for that in that world.
Yeah, I mean, I think it goes back to my earlier comment. I think I see a world where value-based care does get more sliced up by disease state, and that there's more collaboration that's mandated by payers and kind of government, Medicare entities that, hey, as a PCP, you're not going to get all these dollars. You have to work with SED, and that'll create that continuity of care across providers and specialists that in its current state doesn't necessarily lend itself to.
Interesting. Yeah, I think, value-based care, it's not just like a buzzword anymore, that people throw on. I think it's something that we've seen, recently over recent years, people take more seriously because it's like we were talking about earlier. It's not just bad financially, it's a bad experience for the patient to have to go to the ER or be admitted multiple times. It's just so much better to prevent these things from happening before they actually do.
Yeah, I mean, listen, for everyone, even for me, who and I'll end on something personal, but even for me, who's deeply ingrained within healthcare, I think I have 400 physicians in my phone. But even in Albuquerque, in which I currently live, I went to a PCP for a GI referral. I cannot get into that GI referral for another 4 or 5 months.
Wow.
Right. And that's just that experience from an access perspective that I think as they look to, kind of a digital companies or solutions to close those care gaps and create a better continuity of care, it ultimately lends itself to these VBC principles that I think others have forged before us.
Interesting. Interesting. So you just closed this, this funding round. Where are you hoping to go in the next, 6 to 12 months? Obviously you're launching, and then where you kind of where do you hope to be, obviously, in the next, 12 months or so?
Yeah, I mean, it's really milestones based. So I think it's one is proving that delivery model, that the wraparound services, the 24/7 access, we hit those specific metrics that are defined in collaboration with our provider groups and the payers. Of those, cost of care, admissions, medication management, NPS, all of those kind of things in which we're measuring. Or ultimately, when you look 12 months from now, when we ultimately raise again, that we'll be able to prove that and say we did have these impact on these kind of cost buckets, and experience for the patient in which we're ultimately providing. And then lastly, from a growth perspective, we are starting with 100 providers, which is a lot. In Arizona and New Mexico, but we are on the verge as well of having several hundred by the end of this year and or early next year, going into that with both networked cardiology partners as well as health systems and payers that are constantly reaching out to us to help solve their cardiovascular spend issues within their networks.
Very cool. Very cool. My last question I ask everybody: when you're not building Karoo Health, how do you find that balance? What are your passions outside of work, if there is that balance?
Balance is a unique word. But listen, ultimately, I think there's two fundamental things in my life. It's Karoo, 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 and my family. Those are really the two things that are the most, and family being first. But that's really where I spend the majority of my time, in the off chance that I'm not working.
Very good. Very good. Yeah, that's certainly important. And then the last thing is, where can people find out more about Karoo Health? Where can they learn more, connect, and any platforms you're active on, as well as where people connect with you as well?
Yeah, they can visit karoohealth.com. Just go through. They can connect with me personally via LinkedIn. Is probably a good site. And then there'll be more kind of platforms and handles that they connect post this fund announcement here in the next week.
Awesome. Awesome. Well, Ian, thank you so much. This has been very insightful to value-based care, and then, the evolving role of cardiovascular medicine. So thank you so much for taking time out of your busy schedule. Really appreciate it.
I appreciate it, Max. Thanks for having me.
Thank you for listening to this episode of the DaVinci Hour podcast, presented by DaVinci Academy. Please be sure to subscribe to our YouTube channel and follow the podcast on your podcast platform of choice to catch the latest episodes. Please leave a comment or a review and share it with a friend. Lastly, you can find all of our podcasts, video courses, and books on our website, dviacademy.com. Thank you for listening.